Great. So again, very honored to be here, and thank you to the organizers for inviting me. So I'm going to discuss implementation of an obstetric hemorrhage bundle and how it changed clinical practice in our hospital system. I don't have any relevant financial relationships with commercial interests, just as a disclosure. So for the outline of my talk, I'm going to just briefly discuss epidemiology related to postpartum hemorrhage mortality, and then I'll discuss what the intervention was in our hospital system, which is this hemorrhage bundle. And then finally, I'll go through how we assessed what the impact of the hemorrhage bundle was in our hospital system. So just to start out, this figure demonstrates proportionate causes of maternal mortality in the United States over the past few decades. And if you look at the group of bars that's on the left, that demonstrates the proportion of death from obstetric hemorrhage from the late 1980s to the early 2010s. And what you can see is that in the late 80s, death from hemorrhage accounted for about 30% of maternal deaths in the United States. But then by the 2010s, hemorrhage only accounted for about 10% of maternal death. However, in New York State, where I am from, hemorrhage was the second leading cause of maternal mortality, according to one recent mortality review. And the trends, until very recently in the US, New York State and New York City have had higher risk for mortality than the rest of the country. So you can see the mortality risk for New York City in the red line on the top, and then for the US, you can see the black line. They've converged recently. Still, the mortality is high, but it does appear that the mortality has come down a little bit. But anyway, in New York State, the mortality was high, and so that led to efforts to improve maternal safety in New York State. So there was something called the New York Safe Motherhood Initiative, and this was a statewide effort in New York to improve maternal safety. And the kind of the core, most important components of this quality improvement initiative were to implement these safety bundles, these groups of recommendations to improve safety for hemorrhage, venous thromboembolism, and preeclampsia. And so I'll just kind of go through what the hemorrhage bundle is very quickly. It has four main components. The first component is a risk assessment and prevention, or recognition and prevention. So for every patient, when they're admitted for labor, we want to see if they're at high risk for hemorrhage. And then we also hope to prevent hemorrhage by active management of the third stage. The second component is readiness. So, basically having the labor floor ready. If there's a large hemorrhage, you have the medications you need, you have the devices you need. If you need to get blood quickly, you can get blood quickly. This all might sound intuitive, but in New York State, there's more than 130 hospitals that provide obstetrical care. More than 100 centers participated in this effort. And so, some centers were on the smaller side and may not have had all these resources organized. The third component has to do with checklists. So if you have a patient with a hemorrhage, it's a small hemorrhage, there's a list of things to do. If the hemorrhage keeps going, there's another list of things to do. And then if you have a very large hemorrhage, there are even further things that you can do. And then there's this kind of a reporting systems component that where you assess kind of what's going on, and and discuss adverse outcomes. I'm not going to discuss that too much. But just to go through what the bundle is a little bit more, here are a list of risk factors that we would use to score patients for high risk for hemorrhage. If they've had a prior hemorrhage, if it's a multiple gestation pregnancy, if they have large fibroids, if we think the baby's very big, if they have a low platelet count, all of these risk factors you take into account, you'd have a score for the patients, and you would increase your index of concern, maybe cross some blood, if you're very worried. And then intrapartum, if they develop complications during labor, chorioamnionitis, prolonged second stage, you add those risk factors. And then here's what you hope to have on the labor floor if you're providing obstetrical care. You hope to have uterotonic medications, the primary ones that we use in the U.S. Besides Pitocin include Hemabate, Cytotec, and Metrogen. You also want the instruments you need. For example, if you have like a cervical laceration or a deep laceration, you want to make sure that you have all of these things available to you on the labor floor. If you wanted to use like a Bakri balloon or similar device for tamponade, you want to have that immediately available. And then in terms of having blood available, we said every hospital providing obstetric care should have a massive transfusion protocol so that if you need a large amount of blood in a short period, you can have that readily. In terms of the checklists for managing hemorrhage, there's 4 different stages. Stage 1 is the lowest stage. This is a small hemorrhage. You might do things like place an IV, give some IV fluid, consider giving some uterotonic medications. If the bleeding continues and you have a larger postpartum hemorrhage, maybe up to 1,500 cc's, at that point, you consider maybe getting some blood from the blood bank, consider giving TXA, maybe putting a second IV line in. If the bleeding continues above 1.5 liters, maybe you proceed back to the OR and get additional help. And then there's some instruction for surgical procedures and hysterectomy if needed. And then stage 4 is essentially the patient's critically ill. So these are like the resources and recommendations that were disseminated across New York State. And we also implemented them at our hospital. Nurses were trained, doctors were trained, everything was reviewed. And so the question is, what did this mean for our clinical practice? Did it change anything? Did it do any good? Did it lead to better outcomes? And I think that, one thing that we immediately recognized was that hemorrhage is hard to measure. There are a lot of challenges in measuring postpartum hemorrhage. If you wanted to look at billing codes alone, that's not very helpful, right? Because billing codes are just dichotomous. They're yes or no. And hemorrhage is a very big difference between a woman who loses 600 cc's and a woman who loses 3 liters. There's really a spectrum of severity. And then we also know that an issue is that doctors don't measure hemorrhage particularly well. Sometimes we think that someone's lost only a small amount of blood when the amount is much larger. Sometimes we're right, but sometimes we're not. But that's an issue. There are also varying definitions for postpartum hemorrhage for vaginal versus cesarean delivery. And the other thing is that we don't want to just know if hemorrhage happened. We want to know what the clinician did, right? We want to know if they gave uterotonics. We want to know if they used the Bakri balloon. There's a lot of things in the process that we'd like to identify in terms of care. There's really a need for granular detail. So the billing codes aren't great, right? But you can't go through every chart. You can't go through 10,000 charts. That's just not feasible. It's too much time, it'd be too much money. So what we did is we did a study from our electronic health record data. And we looked at 4 hospitals that are in our system, including Columbia and Cornell. And the objective was to determine, in terms of the New York State hemorrhage bundle, what were the effects? So we looked from June 2014 to July 2017, and we analyzed more than 40,000 deliveries that occurred in our system. And within the EHR, or electronic health record, we looked at a bunch of things. We looked at the drugs, the uterotonic medications that were given. We looked at blood bank records. We looked at laboratory values. So we looked at the hemoglobin and hematocrit before delivery compared to the lowest point after delivery. We looked at platelet levels, renal function, markers of disseminated intravascular coagulation. We looked at use of devices. Specifically, we used the Bakri balloon a lot for tamponade, so we queried for that. And we looked at risk for hysterectomy. And then we published our paper with this analysis in the Green Journal. And I'll just go through some of the highlights of our analysis. So the first thing that we did was we created this framework for hemorrhage, where you have different levels of hemorrhage. So level 1 is the lowest level, level 4 is the highest level. Level 1, it's just that a patient received uterotonics. Level 2, it's whether they had a billing code for hemorrhage, with or without uterotonics. Level 3 is they either got a Bakri balloon or 3 or less units of blood. And then level 4 was hysterectomy or high volume transfusion, so 4 or more units. So we kind of came up with this construct by looking at the data, playing around with these parameters, that type of thing. Okay, so great, so we've come up with this. What does it mean? Is it clinically useful? So I'll show you on the next slide. This slide, these bar graphs show how we tested our different postpartum hemorrhage levels. If you look at the group of bars on the top, that shows you the proportion of patients who had a greater than 40% hemoglobin drop from before delivery to after delivery. So we thought that was a pretty big hemorrhage. If a woman's hemoglobin drops more than 40%, she probably had a significant postpartum hemorrhage. And you can see the proportion of patients increases by hemorrhage level. So the first bar, you can barely see it. It's like an orange bar. That's no hemorrhage. So very few women with no hemorrhage had a greater than 40% drop in their hemoglobin before compared to after delivery. But then as you go from level 1, 2, 3 to 4, from pink to orange to green to blue to purple, you see that the proportion of patients with a big hematocrit drop increases. So, we thought that was good. We thought that our framework was mapping on to what the clinical outcome was of importance, which was this big hematocrit drop. The next thing that we did was we used our framework to look at severe maternal morbidity, which is the next set of bars, SMM. And basically that shows you the same thing. Your risk for SMM is very low without postpartum hemorrhage. But as you go from postpartum hemorrhage 1 to 2 to 3 to 4, your risk for SMM goes up. Now, the SMM composite, we're cheating a little bit because it includes transfusion and hysterectomy, which are also exposures in our framework. So we did a second analysis where we looked at severe morbidity again, this composite that we got from our CDC. We excluded transfusion, we excluded hemorrhage, but we see the same pattern. So the bottom group of bar graphs, we see that risk for severe morbidity goes up as you go from postpartum hemorrhage level to level to level. So we thought this was nice. We thought, okay, now we have a framework, and you can run this with all of the data in the electronic health record, right? You can run it on 1,000 patients, you can run it on 100,000 patients, like very nice way to kind of get some detailed information about this outcome. So the next thing that we did was we kind of applied our framework and looked at these management parameters over time because we wanted to see what the effect was of our intervention, of applying this hemorrhage bundle to our hospital system. So here's the next slide. And so this is what we found. We created adjusted models for a bunch of outcomes. We found that over the study period, if you look at the left column, postpartum hemorrhage 1, which is just the uterotonics, that went up. Postpartum hemorrhage 3, which could be either Bacri balloon or lower volume transfusion, that went up. And then in terms of interventions, if you look at the interventions, uterotonic use went up significantly. Bacri balloon use went up a lot, and lower volume transfusion went up a lot. So those three things went up in terms of before compared to after our intervention. The thing that went down was hysterectomy for uteronatomy. So hysterectomy, the odds were about half, 0.52, before compared to after. So we thought that this was good. We thought that this was very encouraging. Uterotonic use went up, Bacri balloon use went up, low volume transfusion use went up, but hysterectomy went down. So we thought that that was, very encouraging. And with this data, there's a lot of stuff that you can do to kind of look at in terms of clinical practice. So what this slide shows is just basically quarterly trends in all these interventions. So how many patients are getting a diagnosis of postpartum hemorrhage? How many patients are getting uterotonics? How many patients are getting the Bacri balloon? So if you look at the Bacri balloon, which is 3 columns over, 2 down, you can see that there's really a significant increase in Bacri balloon over the study period. And then if you look at the 4th column, hysterectomy, you can see on the bottom there that hysterectomy went down significantly. So the key findings, I would say, from our analysis was that we really feel like we were able to phenotype hemorrhage meaningfully in terms of EHR data. We felt like we came up with a construct that reflected what the process was and what the clinical management is. And I think that there are unique advantages to EHR analysis for hemorrhage. Some things are easy to look at, like hypertension. If someone has a high blood pressure, easy to figure out if they get antihypertensives. For VTE, easy to figure out if prophylaxis is applied. But hemorrhage is a little bit more complicated. And we were able to see that our hemorrhage bundle resulted in some significant changes in practice. More frequent uterotonics, more frequent tamponade, more frequent transfusion, and less frequent hysterectomy. Great, thank you.